Welcome to this week's edition of Ask an MS Expert. I'm John Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 100 countries around the world with the news that people affected by MS need to know. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact a family. I'm a past member of the International Progressive MS Alliance Scientific Steering Committee. Currently, I'm a district activist leader and trustee for the National MS Society, and I chair the Society's California Government Relations Advisory Committee. The MS Society's Ask an MS Expert webcast is designed to give us a place for the MS community to connect and to connect you with experts who are ready to answer your questions on the topics that impact people affected by MS every day. Please feel free to post your comments and questions on Facebook, YouTube, or Twitch. MS navigators are online throughout today's program, answering those questions and connecting you to resources. MS occurs most commonly in adults, but it's also diagnosed in children and adolescents. Today, we're talking about pediatric MS and how to manage it as a family with Dr. Brenda Banwell, Chief of the Division of Neurology and co-director of the Neuroscience Center at the Children's Hospital of Philadelphia. Dr. Banwell is the holder of the Grace R. Loeb Endowed Chair in Neurosciences, and she's a professor of neurology and pediatrics at the Perelman School of Medicine at the University of Pennsylvania. Welcome, Dr. Banwell, and thanks for joining us.
Thank you for having me, John. I'm delighted to be here.
Well, to get us started, tell me, how common is an MS diagnosis in children? And when we're talking about pediatric MS, what ages are we talking about?
Sure. So if we look at the evidence to date, about 3% of all individuals who live with MS experience their first event prior to the age of 18. So it's a rare condition, and it's certainly a small percentage of the total MS population that begin their journey with MS during childhood or adolescence, but it is perhaps more common than people realize. In terms of the age that defines pediatrics, that actually depends on where you live. So if you are in North America, most people define pediatrics as 17 years, 11 months and younger, although personally I look after my patients until they turn 22. The American Academy of Pediatrics defines pediatrics as under age 21. And in many parts of Europe and the Middle East, ages 14 and older move to adult care. So it's extremely variable.
Does MS affect kids differently than it affects adults?
So the presentation of MS in children and adults is relatively similar. Basically 100% or very close to it of children experience relapsing remitting MS from onset. Primary progressive multiple sclerosis does not appear to be a condition that starts in childhood or teenage years, or if it does, it's exceedingly rare. The types of attacks are generally similar, with the exception that very young children, which is an even less frequent presentation, so children between, say, 4, 5, and 11 years of age, may be more likely to have a presentation with what we call encephalopathy or drowsiness at the beginning of their first attack, which is a relatively rare presentation in adults. Overall, though, MS in children and adults looks actually quite similar in terms of relapses.
We heard from Jake, who tells us that he's read children and teenagers tend to have more frequent relapses than adults. And Jake's wondering if this means kids will develop more disease progression over their lifetime.
So Jake is correct. The natural history of relapse rate in pediatric MS is higher than the relapse rate in adults. The highest is in children who start their disease journey under age 11, and they have the highest relapse rate. And then second to that are teenagers. And next on the list are young adults between 21 and 30. So that is correct. Relapse rate is higher. Children seem to be very responsive to treatment, and that's really important because that also mitigates relapse rate, often very effectively. Children rarely acquire physical disability in the first 10 years post-onset. Untreated, looking at data in the New England Journal published now a number of years ago of untreated pediatric MS patients, showed that the entry into secondary progressive MS occurred in about half of pediatric onset patients 20 years after their first attack. So on the surface, it sounds like that takes a much longer period of time than adult onset MS. The problem is those patients are only 35 when that happens, right? If they start in the younger age group, 20 years means they're in their 30s. So I think we can all agree that that's a serious outcome. We all hope that the highly effective therapies are changing that story. And certainly there's a wonderful study that just came out of Italy last year that shows that the advent of highly effective therapies has reduced disability in pediatric onset MS patients by over 70% in the most recent decade.
That is good news. You know, teens experience so much growth mentally, socially, and physically during their adolescence. What kind of impact does MS have on a teen's typical development?
So very little impact on physical growth, particularly, again, with effective therapies. We use far fewer doses of steroid. If you don't have relapses, you're not experiencing frequent treatments with medications like corticosteroids, which can affect growth. So since that no longer is the normal history for MS patients, we really are talking about mental development and emotional health. And here we have some significant issues. So about a third or more of pediatric onset MS patients will struggle in high school. They need extra help. They struggle with academic achievement. They need resources and often a different style of learning because rapid information sometimes just isn't absorbed as well as it was before their MS started. At least 40 to 50% of my patients, and this is true across others, endorse depression or anxiety. And I think we need to be very mindful that emotional and mental health is a crisis for teenagers in general, and it is particularly so for some of my youth with MS.
We heard from Shauna, who tells us that her 18-year-old daughter was diagnosed with MS last year. She's wondering if her younger children could also develop MS, and Shauna has two questions here. First, she's curious as to whether there is a genetic component to MS, and then what types of signs should Shauna pay attention to in her younger children?
All great questions. So multiple sclerosis is a complex disorder that has an interaction between your genetic risk and your environment. It is not purely genetic. So it's not what we would call entirely heritable. What that really means is the rate of multiple sclerosis in identical twins is 30%, which means 70% of identical twins, one will have MS and the other will not, even though they grew up, generally speaking, in the same home and acquired the same or similar environment exposures and share very close genetics. They still don't both develop MS 70% of the time. So I think that's an important piece of information. In people who aren't twins, your lifetime MS risk by having a sibling with MS is approximately 5% of your boy, 5% if you're a girl, and 3% lifetime risk if you're a boy. So you can flip that around and say 95% of her children, if they are males, and 97% of female siblings will not experience MS in their lifetime. The genetic risks are complicated. It's not a single gene. There's no MS gene that conveys risk. What we do know is there's over 250 different parts of our genetic code that, when spelled in particular ways, can heighten your lifetime MS risk. None of them individually conveying even close to 1% risk. So it's complicated. And I think the take-home answer would be that it is very unlikely that her other children will ever experience multiple sclerosis, but not zero.
You know, MS, disease-modifying therapies, or DMTs, are effective at preventing relapses. More than 20 DMTs have been approved by the FDA to treat adults. I guess two-part question: can children take DMTs? And I think you started to answer that already. And has the FDA approved any DMTs specifically for kids?
So there's one FDA-approved therapy for children, which is fingolimod. which is a sphingosine 1-phosphate inhibitor, which in English means a medication that acts by basically holding immune cells in the places where they are matured. So lymph nodes and a gland called the thymus, which reduces the amount of immune cells in the bloodstream. If you have fewer immune cells in the bloodstream, you have fewer gaining access to the brain or spinal cord or optic nerves. And it's thought that that's one of the reasons that this therapy reduces MS relapse rate. The approval for fingolimod was based on a very well done study that demonstrated that fingolimod was superior to the comparison medication, which was an interferon beta 1A product given by weekly injection. So fingolimod is approved. In Europe, both fingolimod and teriflunomide, they're both tablets. Teriflunomide was approved by the European Medicines Agency, but the study of that medicine did not show that it reduced the time to next attack, and therefore the FDA did not approve that therapy for children. Many reasons for that, none the least of which is this is a very difficult study to do, and enrolling children in clinical trials is challenging. Many people use what are called anti-CD20 therapies. Others on the call might recognize those as medications like ocrelizumab or similar medications, or also known as Ocrevus, another product, Kesimpta, in the adult world. And then others, medicine called Rituxan or rituximab. These are all anti-CD20 therapies, and there are other examples. They are very commonly prescribed, even though they are not yet FDA approved, and there are ongoing studies of these therapies that are currently enrolling pediatric MS patients. Those are just a few examples, but most of the medicines that adults have access to are not formally approved for children.
Madison tells us that she's 16 years old. She lives with MS, and I think Madison wants to know something that a lot of adults living with MS also want to know. She wants to know which of the medications is best for her.
So Madison, I can't answer that. That's a conversation you and your doctor have to have together. There's no simple answer to that question, although it's a really, really important question, and you need to be the one asking it. As a 16-year-old young woman making life choices for yourself and your body, you need to be the one to talk to your doctor about what is most important as you balance different types of medicines, how they work, how they're taken, and your lifestyle. So some medicines are tablets, and some of my teenagers prioritize that above everything else. Others choose infusion-based treatments that might be given 2 days a year or 4 days a year, and then none in between, because to them, that means that they don't think about their treatment most of the year. For other patients, there are monthly infusion therapies that might be better suited to them. Your doctor will look at all of the things that would weigh into that decision and have that conversation with you. There is a field moving forward now called precision neuroimmunology, which in concept is the idea that we might learn someday to take a blood sample, for example, look at yours, like your own immune cells, and identify whether you might be better with treatment A versus treatment B, based on what your MS biology looks like, not somebody else's, but yours. And then when on treatment, measuring that again to say, are you responding to this medicine the way you're supposed to? And is it optimal for you? Is it the best choice based on your disease activity? We're not quite there yet, although lots of us are trying really hard to be there. So for now, there are many good choices. Your doctors will need to advocate because you're under 18. So we all need to advocate for access. And I think we help with that. Many of us help other doctors gain access to treatment for their patients. And then the two of you together will choose your treatment.
Well, that new framework for treating MS that you just mentioned is certainly an exciting one. I know we'll be hearing more about that. While we're talking about disease-modifying therapies for a moment, something that people often hear is that it's very important to be consistent in taking your DMT. Maybe we could spend a moment and you could explain why it's important to be consistent in taking your DMT.
Absolutely. So adherence, which is taking something that's been prescribed in the way that it was prescribed, is a really important aspect of care. Simply put, nothing works if you don't take it. And very few things work optimally if taken differently than the way they were designed. And drugs are designed and prescribed with a frequency and a number of, a dose that has been carefully studied. So if you change that, you run the very real risk that the medicine won't work best for you because it's not in your system at the right dose at the right time. So this is particularly challenging with the tablets, because of course, if you're taking something every day and then forget for several days in a row, you will go several days with the amount of medication drifting down and out of your system. Really importantly, for the medications that are similar to fingolimod or fingolimod itself, there is what's called a first dose effect with that medicine, where we have to, with the first day that you ever receive that medicine, it's required that you be monitored to make sure that you don't drop your heart rate a little bit. This is not typically dangerous. None of my patients have had challenges, but it's a required monitoring step. And if you miss more than 10 to 14 days of your tablets, we have to do it again and monitor you when you restart. So that's just an example of what happens if people don't take their medicine regularly. There's a step and a safety component to that. With respect to any of the other medications, the same thing applies. If something is given very irregularly, then you're going to run the risk that you'll have windows of time where your immune system is no longer being controlled, and that can lead to disease activity.
We heard from Andrea, who tells us that her son Jack has MS. Andrea wants to know if there are strategies other than medication that can help manage symptoms like fatigue, pain, and problems with memory and learning. Along with medications, we know that good lifestyle habits contribute to overall health and can impact disease progression. What types of healthy behaviors should kids focus on?
All right, so that's also a wonderful question. So first of all, and I've said this on other interviews before, wellness is not the absence of illness. Wellness is something we actually bring to ourselves. It's our own investment in our health. As a consequence, it's a really important part of MS care. It's part of personal care. There are things that make a difference, specifically in multiple sclerosis, though. So we do know that the rate of multiple sclerosis worldwide is increased in individuals with a higher body mass index, which in English means having a heavier body sort of shape, because adipose tissue itself is inflammatory. So healthy body weight is an important component of reducing, if you will, the inflammation potentially in your body and potentially helping your disease. Physical activity is important. It improves muscle health, it improves bone health, and there's been multiple studies that have shown that individuals that are able to engage in regular exercise have better mental health as well as overall physical health. During teenage years, those sort of physical attributes may not immediately show benefit in day-to-day life, but what they will do is reduce other things that we know make MS worse. Type 2 diabetes, hypertension, cardiac disease. All of those are risk factors that you control somewhat by what you do as a teenager. Very importantly, and just I can't emphasize this enough, please do not smoke. Cigarette smoke or any other smoke into the lungs can stimulate what are called the alveolar immune cells, or the cells in the lung that are inflammatory. And so smoking has been shown to make adult MS worse, disability, for example. Secondhand smoke is a risk factor for pediatric MS, and smoking in general puts everyone at risk for other health complications. So smoking would be a choice that one would have to make or not make in life. And I would strongly advocate that all individuals living with MS, anyone, frankly, I'm a doctor, so everybody should not be a smoker, but particularly people living with MS and their families.
I like to say that research is the engine that drives and delivers the future. It's a way we discover new treatment approaches for MS. What can you tell us about research that's currently focused on pediatric MS?
Oh, there's lots to share, and I'm delighted that that's actually my answer. I think 25, 30 years ago, we were focused on whether multiple sclerosis even happened. in childhood and whether multiple sclerosis was a single disease across the age span. And a lot of initial research was actually addressing those two fundamental questions. And I think we, the global community, have definitively shown that multiple sclerosis is an age span disease. It's not two different diseases, one in children and one in adults. I mean, children express their disease differently, perhaps, than somebody who's 60, but that doesn't make it a different disease. So the research that's going on now, and I hope I do justice to the many different parts that are ongoing, include the precision neuroimmunology that I mentioned before. So looking at the immune system of children and teenagers living with MS. So far, that work has shown that the immune system in children with MS is dysregulated, which means that we don't have enough of the policemen in the immune system and too many of the sort of what we call effector cells, or the cells that attack. And I'm simplifying, but that balance is not normal in children with multiple sclerosis, and it's one of the targets of treatment. There's been a couple of studies that have shown that the immune cells in children living with MS look like the immune cells of much older adults with MS. In other words, they're old cells. They look older than the child's age, which suggests that one of the problems might be that there's an aggressive change in the maturation of immune cells that pushes them into a cell type that is behaving like they've had disease a lot longer than they have. These are also important insights. I won't answer this question too long because I could go on too long in the podcast, but there are numerous studies using MRI or photographs of the brain to understand the impact of MS on the developing brain and the teenage brain. And then there are studies on lifestyle. So there are studies on the benefits of exercise in teenagers and children with MS, studies looking at whether marijuana is good for you or not good for you as a teenager with multiple sclerosis. And that's, again, a life choice. And then there are important studies on mental health, quality of life, and the quality of life and mental health of the entire family. And that, I'm sure I've missed things, but those are some of the big categories.
How do you see research studies that are focused on pediatric MS also helping adults who are living with MS?
So I think one of the most important things that children teach us is the beginning of this disease. So, when there are many studies that have shown that when you have your first MS attack and we take a photograph of your brain, we see changes that didn't just happen on Tuesday. They've been there a long time. When the doctors measure spinal fluid, there are something called oligoclonal bands, which are proteins made by the immune system bathing the brain. That also didn't just happen on the Tuesday that the patient came in with that first attack. They've been there and took time to develop. And as a consequence, that tells us that the MS disease process starts well before that sentinel first clinical attack that brings you to the doctor and brings you to the emergency room. If you imagine that someone starts their MS journey when they're 8, by sheer definition, they could not have had very many years to build the immune system abnormalities, to experience the environmental exposures, to activate the genetic signatures that are relevant to cause that disease. So an 8-year-old, for example, might have the clues to the beginnings of this disease, the key things that have to happen in order for MS to start. And I think that is what has driven a great deal of the work I've done. It's driven a lot of the work of the pediatric MS field. And I think it is a pivotal contribution that our pediatric MS community have provided to the entire MS community.
Earlier, I heard you say that it can be challenging to do clinical trial studies with children. Why is it so important for families to participate in pediatric MS research? And how can a parent or caregiver learn more about that?
Fabulous. So first of all, I have the fundamental philosophy that if I can't offer an opportunity to better understand your child's disease, or to the child or teenager to study your health, then I'm not doing my job well. And I believe research is a continuum of clinical care. Clinical excellence to me is understanding better what's going on and better designing therapies. So I think discovery is the word I prefer. And we have been really supported by the amazing children and teenagers that I have partnered with since I started my journey studying and caring for children living with MS. And it was those patients who gave blood samples when they came in, who have undergone extra MRI scans for me, who did mouth swabs so I could study their genetics. Many of the discoveries that the team that I work with have been entirely due to the fact that the pediatric patients have contributed to all of this work. And I will also add very quickly that that's also true of their friends and their community. In order to understand whether something's relevant to multiple sclerosis, I need to compare to teenagers living in the same environment who do not have multiple sclerosis. And I've been thoroughly impressed by the generosity of teenagers and children when asked to help a friend or help a colleague or help somebody in their community they don't even know. The generosity of participation and how good they feel about knowing they helped make a discovery that improved the lives of somebody else's child is really important. So I think, first of all, being part of discovery is how we help each other. When I talk to my patients, and we send newsletters in the studies that I run back to families to say what we've discovered in the last year and what they contributed to, they're very proud of it. They've helped their community, and they know that. In terms of clinical trials, where we're talking about pharmacology trials, where you're enrolled and you're receiving drug A versus drug B, this is how we prove that a medication is safe. Of course, we're very careful. That's one of the reasons trials in children come much later than adults, because we don't launch the trials in the pediatric population until the safety profile in young adults has been very carefully reviewed. But once we have confidence in the safety, and again, we don't study every drug in children because not every drug is thought to necessarily be quite as safe. So not every drug will come forward for pediatrics, but the ones that have a very good safety profile, we need to know if they work. We need to know if they work as well, or what we're learning sometimes is they work even better than they appear to work in adults. And further to that, if we want to have a medication made more accessible here in North America or anywhere else in the world, the regulatory agencies need to approve it. And regulatory agency approvals requires data. And so it's a tough thing to do. Clinical trials take time, but they also provide incredibly good care, very careful monitoring, and a lot of expertise. So I think most of the families I've worked with that have participated have found it to be an important experience, but they would all tell you it is a time commitment, and we recognize and thank them for all of the countless hours that they have provided to basically all of our community.
Getting the best healthcare often starts with finding the right healthcare provider. How can someone find a pediatric neurologic specialist, and what can they do if there isn't one in their area?
Right. So these are really important questions. And, a pediatric neuroimmunologist or a pediatric neuroimmune specialist does not exist everywhere. Child neurology isn't even all that available in certain parts of the country. And there are countries that don't have child neurologists at all. So this is where helping each other at the professional level and helping our patients by doing that has been so important. So many of us have a variety of ways to provide increased access and health equity for patients in my region and across the country. And then, of course, I even see children from all over the world. We'll work to have a family come to see us for an important visit. And then my main goal personally is to then link back to their provider at home and share care from there, which allows me to remain engaged, provide advice, and reduce the number of times that a child and their family have to travel. That works incredibly well. It's difficult to provide phone support healthcare. First of all, you barely have all the information you need, and we always want to be sure we provide the most informed healthcare. So I encourage families to look to the regional MS societies to find out who's in their region. Even if they see an adult MS provider and that person reaches out to one of us that specializes in children, we can often link and then provide good advice and counsel in collaboration. I think the other important message I would share is the medicines we use are incredibly effective now, but we use them with responsibility. They're not really ideally meant to be prescribed by people who don't use them regularly. But they can be prescribed by people who do, and then the monitoring can be shared with regional providers to make sure we keep everybody on the right treatment for them and safe.
An MS diagnosis can be particularly challenging for a teenager and their family. Finding resources and building a strong support team can make a real difference. So for kids who may experience MS-related cognitive issues or frequent hospitalizations, what can parents do to get support from their school?
Great. So our schools need to be our allies. So the very first thing I do when I have a pediatric MS patient who needs support from the school is I very specifically talk to the student to say, are you ready for me to share your story with your principal and your nurse and the guidance counselor? Because I won't do that without the endorsement of my patient. They need to be comfortable that we're advocating for them at school. And that sounds sometimes like a strange sentence, but it is often different, the perspective of the teenager and their parents. Parents are very keen for the whole school to know to get everything going. And teenagers are not always ready for that. And they don't always want that story shared on their behalf. So first is to make sure everybody wants the communication to happen optimally. And most of the time, this is, once we talk about why we're doing it, most of the teenagers and younger kids are enthusiastic to get the support they need. But I do take the time to be really sure everybody's ready for that discussion. Second, we do our best to provide a detailed neuropsychological evaluation. So looking at how a child learns, what style of learning is better for them, where do they have challenges, where do they have strengths, so that we can provide the school with a template of ideas to say, you know, this particular student is struggling with recent memory, but their recall of well-established information is rock solid. So here's how we can help them learn in a way that will facilitate what they do. For my patients that have fatigue, we have a conversation with the school about how heavy the backpack is. Can we please reduce the heaviness of the backpack? Now, this has gotten better with online and tools that are not always in heavy textbooks anymore, but it used to be a bigger issue. And then also just cognitive fatigue. Do they really need to do 20 questions, 19 of which are the same as question one, or would be or are 3 reasonable, or 4? So that a fatigued student doesn't experience exhaustion trying to do their homework at night when they understand the concept. So there's a lot that can be done in partnership with the school. And I think that has been really helpful for my patients.
How helpful is it for families to connect with other families who are going through a similar experience? And how can families who are affected by pediatric MS go about finding that kind of support?
Absolutely. So the National MS Society is certainly in the United States the main resource, and National MS Societies in different countries remain what I would say is the main go-to for families. They're certainly well-resourced. The information that is available to families has been provided by people working with children and teens with MS, and a lot of effort has been placed in providing information and connections. There are families that get together and there are summer camps. I mean, things got a little off kilter with COVID, but summer camps that are available for youth with MS to meet each other. And I think it varies for different families. I have some families for whom connecting with other families has been absolutely incredibly valuable for them and for their teenager or child. And other families where that wasn't what they were ready for, and it was the information they needed. They weren't necessarily needing the direct connection. Similarly, same thing for my patients. Some really love to talk to other teenagers living with MS and feel empowered. Others aren't ready for that yet and take a little time. Not every teenager wants to talk at all. If you've ever worked with teenagers, it takes a while to get a teenager to talk to you. But once you do, you can really learn what it is they want to talk about. And it's not always their MS. What I have found is that by providing resources and sharing ways to communicate, a lot of my teenagers, as they become young adults, really engage with the MS societies or regional support groups. That's when they seem to really connect. And I've had several of my now adult former pediatric onset patients share with me that part of their transition into adulthood was to become an advocate for transition into adulthood, to help other teenagers juggle things that teenagers aren't supposed to be juggling. You know, worrying about your disease and where you're going to get your infusion therapy when you're supposed to be going out to the college football game. Things that they've had to navigate that their peers have not.
You know, you've shared so much important information today. Our conversation has felt like a masterclass on pediatric MS. What would you say are the top 3 takeaways that you'd like our viewers to remember?
So I think number one is that pediatric onset multiple sclerosis is a treatable disease. There are highly frequent relapses in untreated patients, but current therapies are getting better and better at suppressing relapse. And it's exciting to look after patients who are simply doing incredibly well relapse-wise on therapy. Number two, mental health is important to everyone. And it couldn't be more important as we go into teenage years, and particularly if you enter your teenage years facing a great deal more than the rest of the teenagers around you. So mental health support, recognition of depression, anxiety, and holistic care are absolutely essential. And I think the third is optimism. MS has, we would like this disease to be cured, and I'd like to live in a world without MS, to quote the society. And that is an aspiration that I can see on the horizon. And I do think that pediatric onset MS patients may actually help get us there. And so I would encourage children and youth living with MS to consider, when asked, if they can contribute to understanding their disease. It is invaluable to us. And on behalf of the research community, struggling to figure this out to make this disease go away, we thank you in advance for even thinking about participating in research or trials.
Well, I want to thank everyone who submitted questions, and thank you for being with us today, Dr. Banwell.
Surely my pleasure, and they were great questions.
Before we close, I want to remind you that the National MS Society's MS Navigator team is your best partner when it comes to connecting you to the very best information and resources on living with MS. And you can reach an MS Navigator by phone, email, or through the Society's website by chat. For information and resources on pediatric MS, including virtual groups just for kids and teens living with MS and their parents, visit the Society's website at nationalmssociety.org/pediatricms. To learn more about in-person camps and retreats for children living with MS and their families, check out Oscar the MS Monkey at mroscarmonkey.org. To learn more about pediatric MS research, visit the network of pediatric multiple sclerosis centers at usnpmsc.org. And to learn how to contribute to and participate in pediatric MS research, visit iConquerMS Kids and Teens at kidsandteens.iconquerms.org/kidsandteens. You can connect with the National MS Society and others affected by MS via Facebook, Instagram, Twitch, Twitter, YouTube, and LinkedIn. And I hope you'll connect with me every week on the Real Talk MS podcast, where I continue the conversation that we start here. You'll find Real Talk MS at realtalkms.com, Apple Podcasts, Google Podcasts, Spotify, Amazon Music, or wherever you find your favorite podcasts. I'd like to thank Dr. Banwell for joining us today. Please remember that a recording of this webcast will be available at the Society's website at nationalmssociety.org/MSExpert, as well as on Facebook and YouTube. I hope you'll join us at this same time for next week's edition of Ask an MS Expert. You can always find our upcoming program topics on the National MS Society's website. And now I have a favor to ask each of you. Getting your feedback on today's webcast is important. So if you're watching on Facebook Live, you'll see a link to a survey pinned to the comments section. And on YouTube, you'll find that link in the program description. Completing the survey makes a real difference. The information you provide helps us continuously improve, and it helps shape future programs. The survey takes just 1 minute, so I hope you'll take a minute to fill it out. On behalf of Dr. Brenda Banwell and the National MS Society, I want to thank you once again for joining us. Please stay safe and make healthy choices.